And many others don't share. They never go even to an emergency services. And it's very hard at the point when problems have become so compounded that it's a crisis. It's hard to alter the young person's health, their mental health, their developmental trajectory at that point in time. So we'll have crisis services, but then we also need our regular mental health counseling, other kinds of services for those who are willing to come in early and get help before the problems have become a crisis. But what we have learned in the US about our regular mental health services and suicide prevention, and I'm guessing some of this applies to other nations, is that we have two huge problems, three. We have a problem of access to services, access to quality services, many disparities in our nation, and we have problems of stigma, self-stigma. The young person doesn't want to identify as someone who needs help, so even if those around them may encourage them, they're uncomfortable, or family and community stigma. What we also find is that although males in the United States across the lifespan die by suicide several times more often, the probability, than females, girls and women, more girls and women come in for these services, more boys and men die by suicide. So our regular outpatient mental health services are not reaching the majority of people with risk. So that's where we come to working on new models. And what we're focused on now is universal screening as a prevention. And this is something that we're doing in general medical emergency departments, where boys and girls, young men and young women come in. They may be coming in because of COVID, because of an exacerbation of a chronic medical illness. Maybe they're coming in because of a violence, a physical altercation and an injury, a traffic accident. Maybe it's a brittle diabetes. Whatever reason they come in for, we're now beginning to work on screening all young people who come in so that we can identify this unrecognized risk. We find many young people, their suicide risk, their personal pain had never been talked about before until we have a chance to say, let's sit down. I care about you. I want to hear what's going on. So we're trying to pair screening, because screening alone is worth nothing unless we offer something to the young person who has risk. So we're working to pair that with a brief intervention in the emergency department with the young person and a caregiver, where we develop a safety plan, where we talk about the barriers to getting services. We try to link them. But even if they don't link, they and their caregiver leave with a safety plan of steps to take the next time there's high risk. And then what we're just starting now in a project actually in Harlem and Brooklyn and New York City is to pair those two with text message follow-up to caregivers. So we're trying to integrate technology that is both supportive and educational about steps they can take with their young person. But bottom line, and what is most humbling, because after working about 35 years in this field, I have not seen our suicide rate in young people go down in the US. Now, maybe it would have gone up more if all of us weren't working in this area. But I think we have to accept that we need new ways, new models. They're not all within the mental health model either. You know, some of these have to do with helping youth with a sense of being heard, helping with belongingness that we've learned is critically important, belonging at school, with friends, with family, and offering other kinds of services that may make a difference, such as support teams that we build around them. Thank you.
Thank you so much for that. I think, we're talking specifically about youth suicide prevention, but what's clear from what the panelists are saying, many of you will realize, is that it is a multifactorial issue. Justine, I want to come to you. It's not an easy topic to have. This is one of those conversations which we're privileged to be able to have and bring different aspects of this issue up front. But as Dr. King just shared, there are many reasons. Thank you. There are many causes that can lead to someone to be at risk, right? We know that it's not just mental health. We know that, for example, you worked in conflict areas. Can you share with us, you worked in the US, UK, India, you've worked extensively in Kashmir, where your foundation is. Can you share with us, what are some of the common challenges you see and what are some of the contrasts?
Very much. Might want to dial that down a bit. Or I'm going to have to speak very loud because I've got no mic now at the moment. I've got no mic. We still have, so is that okay now? Thank you, Lisa. I wanted to pick up on some of the themes that have come up because they're very common to what we're talking about. 30, 40 years is one of the things that keeps coming up. 30, 40 years ago, the internet started. And when you look at the trajectory of the increase in suicide, Cheryl was saying that it's, very sadly, this is not something, in spite of all that we know, all that's available, in spite of the fact that stigma is theoretically decreasing around mental health. Suicide is what Elon Musk may want to go to Mars, but actually the final frontier is suicide. It is the thing that, as human beings, it's as if we're allergic to it. It's like the disease that is so frightening, we want to stay away from people. So when we talk about stigma around it and self-stigma, as Dr. Lakshmi was saying, it's like a form of self-cannibalization. We're so frightened of what other people are going to think about us. As Arjun said, we become mute. And there is a term, mute psychosis. People actually lose the ability to speak. They are so terrified. They are so sure that they are worse than anyone else, that there is no other person in the world who feels as bad as they do and who can relate to what they're going through. Hence this idea of not the frightening figure of the psychiatrist, as Dr. Lakshmi was saying, but somebody to simply be by your shoulder, somebody to listen to you, to be in your presence. When you are that hopeless, when you are that afraid, the idea you want to be alone, you don't want other people around you, you don't want to be questioned, you don't want to be challenged, you don't want to be examined, but also you're terrified to be alone. So a universal theme is the arrival of the internet around the sort of 93, and then it builds up, is exposing the world to people, which is fabulous, except it taps into insecurity. So the trajectory of mental health begins to climb with the arrival of the internet because insecurity, social anxiety begin to pick up. The line goes up like this, and then in 2008, it goes vertical. 2008, the arrival of the iPhone, the smartphone. Suddenly everybody has a computer in their hand. They are able to compare and contrast anywhere around the world. They are looking at people's social media feeds. Every insecurity of our basic design is being tapped into. Your life is not good enough. You're not doing well enough. You need to do better. And even though the part of our brain, our critical thinking, our logic, tells us that people manipulate their images online, that they photograph their fabulous food, their fabulous life, their wonderful holidays, we know logically that this is being massaged, that we're being, in a sense, sold a lie, but our psyche, our survival mechanisms buy into it. They feel insecure. And one of the ways that, as you said, addressing it is with young people. I was saying earlier on, I was being slightly teased for the fact that I'm not on social media, because we tell people when they are in that state of total despair, try not to compare, try not to contrast your life to others. And this idea of digital detox. This is a very universal idea. So India, with its very high rates, India's exposure to the internet, and I'll take the example of Kashmir. While the rest of India had access to the internet, Kashmir did not for a long time. when it came in so fast and furious, and the suicide rate went up. Specific areas, specific vulnerabilities, people who are very at risk, sensitive people are very at risk, people who are labeled as being more introverted are very at risk. Those who have some kind of pre-existing condition. There are, for example, one of the most common things that leads to suicide across the ages is a UTI, a urinary tract infection. They are so common, and they have an immediate psychological impact, which is despair, and there is a very sharp correlation between people who have got psychological problems from infections in the body, which manifest in the mind. Dr. Lakshmi said that people kill themselves. They don't necessarily want to die, which can sound uncomfortable. They try to kill themselves, but they don't want to die. They don't want to feel the way they're feeling anymore. But in that state, it seems the right thing to do. You convince yourself that this is the best thing to do. You convince yourself that you should not be in the world anymore, that you will be doing the people around you a favor if you are no longer alive. And when you reach that level of despair, to simply know this idea of volunteers, Dr. Lakshmi, somebody like you, somebody as normal as you, can listen to you, can hear you, and won't judge you. They will sit there, and you will see empathy in their expression, in their body language, sadness, the idea of a shared story. One of the big rules about anyone in any kind of despair or suicidal ideation, as it's called, or approaching the idea of suicide is, please never say to them, oh, I understand, because their pain feels uniquely theirs. You may have been through exactly the same experience, but your experience will still be slightly different. To be simply there is an enormous, enormous step forward. So for India at this stage, well, you know, India, it shouldn't be in any way a derogatory fact. Finland has one of the highest suicides in the rates in the world. It's also famous for being one of the happiest countries in the world. So the nature of human despair, when it comes, it can come very fast and furious. A lot of people who attempt suicide hadn't even been really thinking about it before. It comes through like a firestorm. Other people will have been planning for a very, very long time. One of my mentors here, the late wonderful psychiatrist, someone called Udayan Patel, said, there is one universal thing that helps with people who are feeling suicidal. Love has the answer. And we don't mean Bollywood, Tollywood, Hollywood love. It is simply to be seen, to be heard, and to be accepted for what is happening to you. Thank you.
You can have the last word. I was thinking, I was just checking. No, that's beautiful. To be seen, to be heard, to know that you're not alone. I think these are the powerful themes that we must take forward. And again, the idea of this conversation was not to depress this room. The idea was to show that there are strategies that work to prevent suicide, to show that this is an issue that actually affects almost each and every family, actually almost each and every person. Because I think, Shivangi, when I come to you, sometimes people, when you talk about mental health for sure, but when you talk about difficult issues like suicide and suicide prevention, people sometimes it's, you'll see that shutter coming down, people thinking this is not going to affect me. I don't need to know this, which I'm glad to say is not our audience here today, of course. Can you share with us some of your experiences and what you think when it comes to this sort of intersectional lens and how we need to look at this? What are some of the experiences and conversations you've had with young people as well?
Thanks, Amrita. So I think we really need to understand the intersectional lens and why it's important in every aspect of healthcare. But I want to ask the audience first, like, how many of you know what is the meaning of the word intersectional? Like, maybe you can raise your hand. So I think less than, like, hardly, I think 10 people. Yeah, so I think I'll start by defining what intersectionality means. It's a term that was coined by a Black American feminist, Kimberly Crenshaw. And it was basically to better understand uh, what Black women go through, like the systemic oppression faced by Black women, which is a part of being race and gender are the two aspects that intersect to kind of combine those two identities and then define, like, make a very different kind of an experience than what a Black man goes through or what a white woman goes through. So a Black woman experiences something very different in that way, and that is what intersectionality means. And it can be for any identity. Like for example, for me, uh, my one of my most visible identities is being a disabled person. But my identity as a disabled person cannot be understood without like acknowledging my identity as a queer person as well. So I'm a queer and disabled person, and that is very important to acknowledge. And that can help explain that. Uh, yeah, thank you. And that can help explain the different kind of oppression that is faced by queer and disabled people. Um, and so, yeah, I think a lot of us young people, we live with intersections and we face harassment, from different places, different aspects of our life, whether it is home, in our own families, whether it is in the hospitals and medical professions, and in educational institutes, and many different places. And I also want to start also by talking about how real this is by bringing up a few young people who we recently lost to suicide, um, a, a few people who come from marginalized backgrounds. So one of the person that I want to mention is Ananya Kumari Alex. She was a 28-year-old, and she was India's first trans woman to be a radio jockey. She died by suicide in Kochi, of South India, because of medical negligence and a mishandled gender reaffirmation set surgery. Second person that I want to mention is Sam. He was a 20-year-old trans person with psychosocial disabilities. He was a student, an activist, and a poet. He died by suicide in Delhi because of lack of support and understanding in educational institute because of his psychosocial disabilities and trans identities. Then finally, I want to mention Darshan Solanki, an 18-year-old student at IIT Bombay, and he belonged to the Dalit community. He was pursuing chemical engineering and he lost his life to suicide due to caste discrimination from his classmates. There are many more. The Union Education Minister Dharmendra Pradhan has said recently that between 2014 and 2021, there have been around 122 student suicides at primary institutions of IIT, IIM, NIT, etc. And out of these 122, 68 students were from reserved categories. And this is something that I think there are, yeah, I mean, this is something that like it really shakes you, it's not because of what these, like, this is institutional murder in a way. And so I think, yeah, there is a clear interrelation between having a marginalized body to our minds because of how we look or how we are perceived from our disabilities, caste, sexuality, and gender. We face harassment, bullying, exclusion, lack of understanding of our needs, lack of accessibility and reasonable accommodation. There is often no safe places for us. We don't, our biological families often don't understand us. Medical professionals, they don't understand us. Educational institutes are one of the leading causes of suicide among young people in India, I think. And yeah, it's a constant fight. I think even to, for basic survival or like getting a house for rent, getting education, even walking down the street sometimes, these are things that are a big fight a lot of times. And when just the act of these basic survival is like a fight, mental health often takes a back seat. And for a lot of us, because of like therapy is completely not even accessible. Like there is so much privatization and increasing costs, which leads to like which impacts marginalized communities even more. We don't have economic rights, we don't have political rights, and so the privatization of mental health makes it very difficult for us to access mental health, any kind of mental health intervention. I think one more thing that I want to talk about is the universal form of talk therapy is not for everyone. I think it's not easy to communicate and verbalize for a lot of young people. And also, what about those of us who are deaf, mute, who have autism? Uh, I mean, there is no place where for us, there is no way that we can, uh, take part in this kind of talk therapy, universalized talk therapy sort of intervention. Another thing is that a lot of times healthcare practitioners, they don't believe us, they don't believe our experiences. Uh, I have had therapists who have not like believed anything that I've been going through, or they will just say, oh, like just talk to this person, or just that is not easy. Um, and so yeah, I think unlike in many other countries, unlike in India, there is no recognition of mental illness as well. Like there is no recognition in what I mean is like there is no recognition of psychosocial disabilities. Many other countries do have that recognition, and because of this, not being able to get a disability certification for a psychosocial disability, there is that means that we cannot have any access to accessible measures are not taken in jobs, schools, colleges, etc. So yeah, I think these are some of the basic stressors that I wanted to talk about that are faced by people from different intersections. Thank you.
Thank you so much, Imangi. That was very moving, very eloquent, and thank you for sharing that with us. Preeti, I'm going to come to you with an eye on the time. I will ask you a question. We're going to check if there are any audience questions because we did want to make this conversational. So if you have a question or you think you might have a question, put your hand up. Otherwise, I'll put one last question to our panelists after this. Can you talk to us a little bit? We're hearing so many different, really important perspectives. Can you talk to us a little bit about the work you're doing and why it's so important to really look at community engagement and what does that actually mean in a real world scenario?
Thanks, Amrita. So if I look at what has been talked so far in terms of what are stressors that young people experience, both Arjun and Shivangi talked about it, how services can be delivered by non-mental health professionals, as Dr. Lakshmi mentioned, by volunteers. And then how Justine was saying that the basic need of belonging and having somebody to hear you when you are in a crisis are important. And also, like Dr. Cheryl said, that let's also start talking about prevention and not necessarily crisis intervention. So what does it look in practice? In practice, it could mean a program that we are funding in Pondicherry, which has it has the second highest rate of suicide within India, as per the NCRB data for 2021, where there is a helpline run by young volunteers for young people to call up. Now, if the helpline is busy, you have the option of leaving your number so that they can call you back, because it's also important to have consent whether you want to be called back or not. And if your issue is to say doing with, I'm not finding a livelihood, then you can drop into the office of this organization. They will help you prepare the CV. They will give you referrals of organizations that you can apply for. They can help you with mock interviews so that you're ready for an opportunity on employment. Because when we talk about suicide prevention or when we talk about mental health issues, I think we need to move away from only a biomedical reason for it and look at a psychosocial reason for it. if livelihood is the cause of my stress, and as Shivangi was saying, economic independence is not there among disabled people, and that's reality, and there is research to prove that, then you can't just talk to me or just do art-based therapy for that matter, and the issue will not disappear. So you will need the referrals and linkages to be in place, which are social benefits of existing schemes that are available for it to be making a meaningful impact apart from the crisis intervention. The other program that we are funding is actually Dr. Lakshmi is doing a research for which we are funding, which is on intergenerational conflict and what does it do to young people. Now, the challenges that young people in India experience or the areas of conflict that people may experience in India could be very different from where or what people in other Western countries may experience because of the way our family structures are there, the way our social structures are there, the way we have also health systems, educational systems, all of these systems. And again, this is an intersectional lens to be brought on suicide conversation. The other program that we fund is not for young people, but we're funding it in Tamil Nadu, in rural Tamil Nadu, is what happens to families and friends when you lose a loved one. So when we talk about suicide, there is suicidal ideation or thoughts, there is crisis intervention, there is prevention, but there is also bereavement, right? For every life that we lose, there are 10 to 20 people who have lost that individual. And what does it mean to then get along with that life? So we have a program which is conceptualized and run by a person who lost her husband to suicide, where she is running support groups with women who have lost a loved one. Now, it could be a child who lost a father, it could be a partner, it could be a mother. And the impact that they're seeing is phenomenal. The program is hardly 6 months into running, and they're saying just the fact that these women could come out and talk that they lost a loved one, that it was not their mistake, but they feel guilty about it, that they need support to carry on life in terms of employment, education for their children, and are these available to them? So just the support group is not sufficient. You need, again, those referrals in. So are there programs being done? I think there are programs being done in the community setting, which are delivered by volunteers who are trained to do this. And whenever we say volunteers or community workers, we are saying they get the adequate training. And with some amount of training, it's possible to do those conversations and make an impact. Because if we say that the cause of the issue is the context in which I live, my access to services, health benefits, then it is best understood by the same community and delivered by the same community. So yeah, there are enough and many programs.
Thank you so much for that. And I would just love seeing these kiddos coming in as we are winding down. We've had an incredible audience. Thank you so much for your attention and patience. I'm going to put one last question to all of our panelists and put them on the spot a little bit even more. This is a rapid fire. If you had the chance for everyone in the room to go, like to get one key takeaway, right? What do you want folks in the room? What do you want the G20 to take away? Preeti, do you want to go first and we can go down?
I would say do conversations on suicide prevention in the work that you do, whether it be on NCDs, whether it be on women and child development, whether it be on One Health, all of it is linked and you can make a difference there. So do conversations.
So I think one big takeaway I would ask people to have is that mental health right now is so separated from political, social, and economic rights. It's very important that there are community-based interventions rather than all the responsibility of kind of healing be left on an individual. For that, it's very important to fund community-based interventions, which places the responsibility on the government. So I think, yeah, that's one of the biggest things I would say.
I would hope that it would be that suicide or thinking about suicide, suicidal ideation is a completely normal human thing. It's part of the human experience. And when someone is going through it, you feel utterly alone, but you're not. You're really not.
I think it's that suicide is preventable. And it's an aspiration to try to prevent 100% of suicides. But we've learned over and over again from people's stories that it is preventable and people's responses make a difference to them. And that when a young person is suicidal or dies by suicide, that is not just that young person's problem or that young person's family's problem. It's really the community's problem. It's society's problem. And every single one of us in the community has a role to play. And it might be learning to recognize signs and helping get that person to help, or just listening, hearing the pain, saying I care. It might be working to get more services, volunteering on a crisis line. There are many different roles. It might be being part of a youth-nominated support team. This is a prevention strategy we've studied for over 20 years. And we've had youth-nominated adults to be part of a team. We help these adults understand, as does the youth, what's going on with them. They bring them closer to understanding their pain and learning how they can be helpful. And we learn, following mortality for 15 years, that it's at least a 50% reduction in the number of deaths among people in their 20s. So people in a community can be part of a support team for youth at risk, but it is a community issue and it's preventable.
I think whatever profession or job you have, whether you're in the media or in the education sector or agricultural sector or teaching sector, the component of suicide prevention can be incorporated in every single program, because suicide is multi-causal, and so there are multiple ways of addressing it. And there is no one way which is better than others. We have to address it always. So whatever work we do, even if you're a housewife, you can incorporate the prevention of suicide as part of your job. For those who are in distress, all I could say is reach out for help. There are people willing to help.
I'll just give two practical advices at an individual level that I learned from my mom a lot many years after my last suicide attempt. First is cut off access to things that may be used. If you know someone who might be contemplating suicide or thinking about it, cut off access to things that they may use. So my mom told me that she'd hide stuff everywhere around the house every night before sleeping. And yeah, it made it easier to, not die at the time. Secondly, it might seem very simple, but if you know some education institute or if you run some educational institute, announce your results in the morning instead of at night. So currently, the National Testing Agency, they announce their results whenever they want. For them, it's like results are coming out at 2 at night, 12 at night, at 11 at night. But that is very difficult for some students to come to terms with. I work specifically with students who prepare for competitive exams. And at 2 at night, when you learn that you have not cleared the exam and now you have to go back to sleep in your room, that is not easy. So just the simple act of announcing your result in the morning and letting it soak in the students, letting them know that there is a way out of this, can prevent a lot of suicides, in my personal opinion. I don't know the research behind this,
I just want to add to what Arjun said, because we have evidence to prove that. We did, many students died due to exam failures. So we did a study and found that the students who died by suicide failed in 1 or 2 subjects by few marks. So with the help of media, we started a big campaign. And in the year 2004, Tamil Nadu government, and we made the representation to the government and said, please give these students hope. And Tamil Nadu government was the first government to start the supplemental exam for both 10 and 12. And in the year 2003, we have statistics to prove that this has given hope and saved many young lives, because in 2004, there were 450 students in Tamil Nadu who died by suicide. And in Chennai, there were 54 students who died by suicide because of exam failure. With the introduction of the supplemental exams, in the year 2021, with 30% increase in the number of suicides, the number of suicides due to exam failure in Tamil Nadu was 250, and the number of suicides in Chennai was 9. So there has been a 150% decrease in the number of exam failure suicide with this simple offering of allowing the students to write the supplemental exam, which we are trying to do it throughout the country now. So these kind of suicide prevention, I think, has to be at all levels. From top down, we had to have laws and policies, and bottom up, we have to have community involvement. And when these two join, definitely, according to our national strategy, we are supposed to reduce 10% suicides by the year 2030. It can be achieved.
I think we'll end on that note of hope, on that note of work that's actually been done, and we hope that all of you will keep these key takeaways in mind and know that you have a role to play. We really appreciate you being such a wonderful audience, and join me in a final round of applause for our amazing panelists.
Thank you, Amrita Tripathi ji, and all the panel speakers for that insightful discussion. We will now move on to the second C20 Integrated Holistic Health Panel discussion, titled Lessons from India, Public Health, Adaptations, and Reflections. This panel will be conducted by the AIDS Healthcare Foundation, India Cares. The Los Angeles-based AIDS Healthcare Foundation, or AHF, is a global nonprofit organization providing cutting-edge medicine and advocacy to over 1.7 million people in 45 countries. AHF is currently the largest provider of HIV and AIDS medical care in the world. AHF India Cares is part of the AIDS Healthcare Foundation and offers advanced medical care for over 3,000 people living with HIV, providing clients with easy access to specialists, medications, and services they would need to remain healthy and productive. The moderator for this session is Dr. V. Sam Prasad, the Country Program Director of AHF India Cares. Dr. Sam Prasad is a practicing public health policy professional for over 2 decades. As a trained medical doctor, armed with a master's in public policy, Dr. Sam has been instrumental in effecting policy interventions for the benefit of PLHA and the marginalized sexual minorities. Dr. Sam has been instrumental in the first ever national free condom store in India and initiating Moonlight HIV testing in India. Dr. Sam also supervises the AHF Centers of Excellence India Cares Clinic in New Delhi and Mumbai, offering free HIV and TB services for around 3,000 patients. The list goes on. He has worked with the World Health Organization for the eradication of polio in India and has been instrumental in implementing programs to strengthen health systems while working with USAID and UNICEF. As a public health and policy practitioner with strong field experience in sociocultural understanding, Dr. Sam Prasad's scientific temper results in innovative program designing for model advocacy in India. I now invite Dr. Sam Prasad to moderate the session.
Thank you, Neetu. That was, I think, a lot said about me, and that will be it. Welcome to the session to one and all. First of all, let me offer our humble pranams to Amma, and in her absence, Shia, and also to Swamiji and all the other people from the ashram, and also the esteemed guests who are participating in this integrated holistic health, session summit today. I think we are one of the few and very lucky people to kind of, experience this hall itself, I know, and this ambience itself is so positive and welcoming. So thank you for all the arrangements. Thank you for the technical team here. The session is named as Lessons from India. Of course, we do have lessons from abroad too. Public health adaptations and reflections, especially in the context of the post-COVID era, as we are now terming it. And we have an array of speakers here. I'm glad that we have people who are joining online as well as who are present here. And it's my proud privilege to also welcome my co-chair, Ms. Loretta Wong, Deputy Chief of Global Advocacy and Policy at AIDS Healthcare Foundation, and she's going to be co-chair. She'll be joining in any minute, I guess, with the technical team. Yeah. Sorry. All right. Okay. Okay. I think it's a technical glitch, but I think we'll just go on with the formalities, and then Loretta will be joining in as quickly as possible. Told. Anyway, so going into the session, if with all your permission, may I request and the August presence of all our speakers here, and also their presence onto the stage. May I welcome Mr. Deepak Dungel from Advocacy and Marketing Manager of Asia Bureau, AIDS Healthcare Foundation from Nepal. Dr. Rajesh Rana, Director, Global Fund, TB Partnership from Plan International India. Another young stalwart in the TB HIV space, please welcome. Help me to welcome Ms. Elizabeth Michael, Director of Operations and Partnerships, India Cares. Another August face in the crowd is Prince Manvendra Singh Gohil of the Gohil dynasty from Gujarat, and also the chairman of Lakshya Trust. Ms. Sunanda Nadarajan, founder of Ek Jeevan Hamari Prerna. Ms. Sunanda, please welcome. Could you be on stage, please? Yeah, thank you so much. Bismay Kumar, Impulse Program Manager from AIDS Healthcare Foundation, Impulse, Chapter New Delhi. And of course, we have Ms. Alessandro Nilo, who is a very familiar face of the C20 from the last couple of meetings. So she also joined in person in Nagpur. She made robust discussions for the sessions here, and she'll be joining online. So I think the technical team will assist us to get us passed. Yeah, sure, passed with Loretta. Yeah, Loretta and Alessandro Nilo. So with that, with our speakers on the days. I'm very happy that the last session started with something called the overlapping, or as we call it, as the overlap of many things like pharma greed, access to nutrition, national efforts and community service organizations, transgender health, women entrepreneurship, sexual minorities, and then going forward into the next C20 with the Brazilian agenda, how we are going to pass it on. So nothing more to say, but then other than that saying that in the last 3 short years of the pandemic, much of our understanding about global public health has been redefined. The world had to adapt on the fly. We have learned new things about fighting global infectious diseases and had to relearn some difficult lessons of the past. What we do with this knowledge and experience will determine if we are ready when the next pandemic comes. Today, a panel of esteemed speakers will help us explore some of these lessons learned. The topics will include equity in access to medicines and pharma greed, the multidimensional challenges of TB, the role of communities and civil society organizations, the way forward on HIV, and the role of C20 in global health itself. With that, I also want to talk about the very first speaker, who is, So Loretta and Alessandra, sorry for the technical glitch here, but thank you for joining us. I hope I'm audible and you can see all of us here. All right, thank you. So Loretta, let me just go on introducing the first speaker, and then we'll take it as and when it comes between both of us. Okay. Right. Okay. So Deepak Dungale. Deepak has been working as a regional advocacy and marketing manager at AIDS Healthcare Foundation, Asia Bureau since April 2021. He has been supporting 9 countries in Asia Pacific region and is based in Kathmandu, Nepal. He joined the AIDS Healthcare Foundation as a country program director manager at AIDS Healthcare Foundation Nepal since 2014. By profession, he is from a public health background with more than 20 years of experience in managing public health programs, which includes the focus of HIV and others. Prior to his association with AHF, he has also worked for FHI 360, Handicap International, and Save the Children UK in Nepal. He did his graduation, master's in public health, and also development management from Philippines. Welcome, Deepak Dungale from Nepal. And, the session that Dr. Deepak is going to handle is all about pharma greed, access to treatment, etc. Over to you, Deepak.
Thank you, Dr. Sam. And first, I would like to thank Amma for all the opportunity, all the initiative that she has taken. And I am very grateful that I had honor to be part of this very beautiful building and the place and the holy place, I call it. And greetings to everyone, including key speakers here and all the respected guests. मैं हिंदी समझ सकता हूँ, लेकिन मेरा बोलने में उतना फ्लुएंट भी नहीं है, इसलिए I prefer to continue talking sharing my thoughts in English. AHF President Michael, our advocacy chief and advocacy policy and communication department chief Terry, and Dr. Sarath from Asia Bureau. They have also asked me to share their greetings to you all. And HF Global leaders, Loretta, who is with us also, and other colleagues, including Ye, who has been to this place recently. They are also with us. In case if I miss anything, together with our AHF Cares team and Prince here, I would like to request them to contribute to the beautiful and meaningful interactions later. The agenda that I will discuss about now is vaccinate our world. In brief, in short, we call it VOW, BHAO. Pharma greed, access to treatment, and thanks to this secretariat for prioritizing this issue for the discussion. Let me begin by taking you all down the memory lane. COVID-19 and pandemic declaration. Let's talk about this. The epidemic made it very clear that the communicable diseases has no boundaries, regardless of rich, poor, whether you live in very developed country or very poor country, women, men, race, religion, nothing. It affects all. And we allowed more people to suffer and more people to die, also because of vaccine nationalism. Because every rich country wanted to protect their people first. vaccine hoarding. They wanted to stockpile the vaccines at their nation because they have money, they have link or the share in their big pharma, they can do it. And delayed declaration of COVID-19 pandemic by WHO, which was announced on March 11, 2020. If it was announced earlier, which was requested so early by AHF also, we could have saved millions of lives. And thanks to PM Sri Modi ji to make available vaccine to its neighbors. Also, when there was very scarcity of the vaccines for his own fellow citizens. And as a citizen from neighbor country, I would like to thank Sri Modi ji again for his leadership. And learning from HIV and COVID vaccine production proved that the regional production made it life-saving drugs and vaccine accessible and affordable. We are thankful that we are living next to India because no other countries had produced the vaccine at the regional level. This is great that we had good experience, successful experience, and the learning from HIV program also. ARV also being produced regionally. That is why the drugs are being affordable and accessible. And we see similar capacity in Indonesia, which is also G20 country, Brazil and other countries too. To know more about how that is vaccinate our world, please visit vaccinateourworld.org. And I call and I request all of you for the collaboration for the global advocacy against all these atrocities, all these injustice related to vaccination and its production and its distribution. Let's talk about pharma greed and cost for the vaccine and treatment. The pharma greed made the situation worse also because the public fund has been invested in their research and development, which they didn't count while pricing the product. The same vaccine could have been produced in India or Indonesia or Brazil with less than $3, but they are charging more than $25. Isn't this injustice? Gilead Sciences is one of the largest 15 pharmaceutical company in US. It is one of the worst offenders of putting profits before people's lives. Gilead has priced several of its HIV drugs and treatment and other commodities, including hepatitis C drugs, HIV-related drugs, which is out of reach of many people. And Gilead refused to register some of drugs in developing countries because of that reason, it is not possible to produce for regional production in India, because India has that capacity, but it is not being allowed. See the situation. And consistently, they are blocking purposefully and making efforts to introduce, and they are the hurdle to have accessible and affordable medicine in the world. When we talk about world, it is not only the developed nations people, not only the G20 people. That is why the leadership of this time, the leadership of Sri PM Modi as a G20 summit, we are very hopeful from his charismatic leadership, maybe world guru, so many things we have been hearing. And this is high time to prove for Modi ji that he is accountable not only to Indian citizens. we feel proud that he is also our leader. Because I represent Global South, though we live next to each other. And I would like to quickly go through other things, the remaining things that includes, like these are all the situation, difficulties, challenges that we have, and what we are going to do next. Solutions to the 21st century public health problems. I would like to talk about these things. Having international organization, which has no, that has no meaning if it is not accountable to the global citizen. And the organization which only listens to the government and ignores the value of communities, hard-to-reach population, and the civil society. I don't know, they can represent wealth, they have a right to talk about global health. In that sense, maybe we have to think very seriously to revamp the structure to make accountable global government where there is say in planning and decision making of the poor, hard-to-reach population, and civil society. And for this, AHF, I would like, in this regard, I would like to thank AHF President Michael Winston and the team of professors and academicians for recommending Global Public Health Convention. Kindly note that you can find the Lancet article on the internet with the title of Global Public Health Convention for the 21st Century. And you can join your hands to make things happen and to make the world a livable place. Trade-related aspects of intellectual property right, we call it in brief TRIPS waiver, and the intellectual property rights, IP rights in brief. The World Trade Organization has a provision to offer TRIPS waiver in case there is public health emergency. We already allowed many people to die, millions of people already died. The COVID came in early 2020, it is already three years, and in 20 years, the intellectual property rights automatically becomes the public rights. There will be no more control of the proprietor. In that case, having delayed decision has no meaning. If you can't make it, please remove your condition or clause that you have put in WTO. In case of emergency, you will allow TRIPS waiver, licensing, or blah, 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 blah. In that sense, maybe the proposal that is raised and submitted by Indian government in collaboration with South African government and some other countries, it has not gone so far. It is still pending. It is already 3 years. Many people already died. In that sense also, this is high time that the proposal was submitted by Adarniya Sri Modi ji, who is the chair of the G20 this time. Maybe he can have bold leadership, persuasive leadership, and so his charismatic leadership to make this issue happen. And maybe such historical decision will help us to deal upcoming future pandemics in saving lives without any delay, so that there will be no more issue related to TRIPS waiver, IP rights, and the licensing issues, so that urgently, immediately, as whenever there is production of such vaccines or medicines produced in US, with no time lag, at the same time, even India can produce that and provide the drugs and supply to the world citizen. This is what we expect. And let's capitalize the capacity of India, Indonesia, Brazil, and other countries. We can supply make a great contribution in respecting, in promoting human rights also. Let's change the narrative, and we also love to support G20 leaders, especially when Adaraniya Prime Minister Sri Modi ji is chairing the G20 India 2023. At the end, let Bhav, Permagrid, access to treatment be the part of policy path that we are going to submit for the G20 Secretariat, G20 leaders. With the aspirational leadership of Mata Amrita Nandamai, we call also Amma, let us achieve our goal from C20 and support PM Sri Modi ji to materialize India's proposal to World Trade Organization. Appeal or demand or humble request to all G20 leaders. PM Sri Modi ji as a chair of G20 India 2023 as a charismatic leader is requested to facilitate to have G20 declaration to fight against vaccine injustice and pharmagrid and decide for affordable and accessible treatment, especially during public health emergencies, current one and upcoming one. Everything, this can be the solution for in solving the 21st century problems. With this, World Guru PM Sri Modi ji from India has another bucket list to prove that Modi hai to mumkin hai. Thank you very much.
Hello. I think, Devak, thank you so much for reiterating the leadership of our Prime Minister. I'm happy that you brought in the point that the vaccine diplomacy initiative led to the distribution of COVID vaccines to more than 100 countries. And that was the stern leadership of our own Prime Minister Modi ji. And we should be very proud about that. And then, that made India stand out during the, complete COVID crisis. Thank you, Deepak, until we have some questions coming for you. Otherwise, we'll go on to the next speaker. Loretta, can I go? Thank you, Loretta. Okay, so with the next speaker in the fray is Dr. Rajesh Rana. Dr. Rajesh Rana has more than 17 years of experience of working in development sector with expertise in advocacy and communications. He was a communication lead at the NACO, National AIDS Control Organization, for several years. I had the opportunity to work with him when he was at that level. Dr. Rana also contributed for developing policies at the national level, designing and managing communication campaigns and leading national initiatives like the Red Ribbon Express, setting up the toll-free AIDS toll-free helpline number 1097, which is very famous. Everybody knows about it, and the enactment of HIV/AIDS Act in India in the year 2017. At present, Dr. Rana is again heading Global Fund Portfolio at Plan International India chapter and working for dual elimination of vertical transmission of HIV and syphilis, supply chain management for HIV and TB, and setting up of one-stop centers for key populations. Dr. Rana heads the TB portfolio right now, and he will deliver the session called TB and Community Access to Treatment and Nutrition. Thank you, Dr. Rana.
I think it's audible. Thank you very much, Sam, for this elaborative introduction. I think we all are contributing for the purpose, and it's really important to be part of this session. And I'm really thankful to Amma, because this session is really important in terms of the place as well. मेरे ख्याल से इससे बढ़िया तत्वाधान नहीं हो सकता था, क्योंकि जब हम हेल्थ की बात कर रहे हैं और जो हेल्थ में अगर हम इस हॉस्पिटल की बात कर रहे हैं, इस इंस्टीट्यूट्स की बात कर रहे हैं, तो इससे बढ़िया वर्किंग ग्रुप के लिए कोई भी वेन्यू नहीं हो सकता था. आई एम रियली थैंकफुल टू अम्मा for providing us this opportunity and this venue and the premise to host this eminent working group sessions. And I'm really thankful to the organizers also to give this opportunity to present what we are doing for community. And as Dr. Sam said, that we have all these opportunities as well as platform to showcase that how even in the pandemic and post-pandemic, the things needs to be taken forward. I'm taking forward what my last speaker said, that Modi hai to mumkin hai. And in this case also, Modi ji has showcased that how the COVID vaccination has been provided not only to India, to global, as well as no one was left without vaccination. So same way in Indian context, if you talk about Pradhan Mantri TB Mukt Bharat Abhiyan, this is another initiative which has been undertaken by Honorable Prime Minister. So I would be just talking about that, how this initiative is actually benefiting all the TB patients, those who have consented to have nutritional support. As we know, India is contributing to approximately 25% of the global TB load. And when we are talking about the TB load, it's not only affecting one particular population or any segment, it's all, whether it's child, adolescent, women, pregnant women, or adult, or those group or productive age group, all are affected and infected by that. So probably it's really important that we talk about such initiatives so that each and every one, those who are part of this working group, those who are part of India, those who are part of all this one family concept, they need to come up as Nishchay Mitra, because this is the initiative which has been launched. So as part of the discussion, I will be just having 4 pointers in my discussion. First is the initiative. As probably everybody would be knowing that Nishchay Mitra is the initiative which has been launched by Ministry of Health and Family Welfare, wherein individuals, organizations, whether these are government organizations or non-government organizations, political parties, or even anyone, those who wants to contribute, those organizations or individuals can be Nishchay Mitra. I would like to quote one example. Even when we were taking this initiative, one school student, he came forward and he volunteered to be Nishchay Mitra. We asked why you want to be, because the response which he gave was कि मेरे को pocket money मिलती है और उस pocket money से मैं कई बार कुछ अपना खर्चा नहीं कर पाता हूँ, in terms मेरे पास savings रहती हैं, तो मैं ये चाहता हूँ कि मेरे पास जो savings हैं, उन savings को मैं किस ढंग से optimally use करूँ. हमने कहा कि आपको ये आइडिया आया कहाँ से? उन्होंने बोला कि यस, मैं काफी कुछ पॉलिटिकल और न्यूज में विश्वास रखता हूं, तो वहां पे जब मैंने मोदी जी का ये भाषण सुना और जब इस टाइप का लॉन्च हो रहा था, तो आई गॉट मोटिवेटेड, और उसी समय मैंने डिसाइड किया था कि जो मेरी पॉकेट मनी आ रही है, उस पॉकेट मनी से मैं कुछ पैसे बचाऊंगा. एंड वी ब्रॉट दैट बॉय टू डोनेट to the TB patients. So it's really something, not only we as an organization, individuals are also making difference, because we matter to everyone and everyone matters to us. That is something which is really important. So this is something which has been put across by all the organizations, that how we have to contribute and how we have to support all these TB patients, those who are willing to have nutrition support. After this initiation, the process which we started was totally different. Like, that boy was interested in contributing, but the boy was not having that platform where he has to go and where he has to donate that money. Same, probably within this room, if 10 people are interested in becoming Nishchay Mitra, so the biggest challenge which we face is where to go, whom to donate. That is the biggest challenge. So we at Plan International, we provided that platform, that opportunity, that you contribute to us. We opened a page on our website that even a 1 rupee donation, 100 rupee donation, or 700 rupees donation per month per kit is welcome. And this initiative was supported by Central TB Division. All the employees of Central TB Division, they started contributing. Even we got contribution from Honorable Health Minister, Secretary, Additional Secretary, everyone contributed. And that contribution made us to adopt one PU, which is a TB unit in Sultanpuri. And this initiative was started in the month of December 2022. From December till now, we are able to provide nutrition support to more than 359 TB patients regularly. As a result of this nutrition support, we are measuring the treatment adherence, the weight, as well as the comfort and what improvement they have got in their lives, as well as in their health. We have noticed that, and I'm happy to share that all the patients, those who were having this nutrition support, they were having increase in the rate in case of weight which they were having. Second, they were not missing even a single dose. Why it happened? Because not only we were providing nutrition support, we provided counseling when we were giving this nutrition support to them. So this amalgamation of kits, counseling, as well as community engagement concept which we developed. So all these three things benefited all the patients so that they could continue. And I'm happy again to share that some of the patients, those who were having TB earlier, they are recovered now. So this initiative, which we started in Sultanpuri, that has been extended to other states also. We are at present benefiting more than 8,000 TB patients across 8 states, which is really, really great. And the platform which has been provided is unique platform because anybody can contribute in that. In terms of process, we had consultation at the national level with CTD, state level with the health department, because state people, they would be having different requirements, because the need in terms of kit at Delhi would be different when we are providing kits in southern states. Here people are more interested in having atta, whereas in southern state people are more rice. Same way in Bihar, they were more interested in having chana or sattu type stuff. Based on their need, we developed the kit and we started distributing that. In addition to that, how the reporting is to be done, which is really important, and how the collaboration needs to be done in terms of DTOs, and that is central TB officers and the state TB officials, so that the information which is coming, that information needs to be reported in the national portal. So this is the process which we followed in that case. When we talk about the impacting humongous, people are coming forward. Why? Because the concept of community engagement is there. The people, those who are taking kits, they are going back, they are advocating that because of all the support, we are getting benefited. And the stigma which was there in the community, that stigma is also getting reduced. So these 3 indicators are really, really crucial when we are talking about how we need to build such type of concepts in terms of providing benefits to any disease. So to say, we are talking about TB, but the same stuff was done for the people, those who are living with HIV, because they also need high protein-rich nutrition. So we extended our support to people, those who are living with HIV. So if we talk about these 3 steps, the experience as well as the evidence is there, which means we, as a next step, we are advocating to go for a bigger nutritional alliance, so that the development partners, NGOs, government, individuals, corporates, they need to have an alliance, so that alliance provide that platform wherein all the individuals or anyone, they can contribute. So based on the need at the state level, district level, wherever we are not having that much number of corporates or Nikshay Mitras, so that support can be extended, as well as we can have a collaborative effort to continue provide nutrition support, so that the objective which has been set, or the target which has been set by Honorable Prime Minister to end TB by 2025, that can be achieved. So this was a small initiative which has been undertaken by Plan International. So as part of Plan International, India chapter, as Sam has already mentioned, but we are doing a lot of efforts. We are working for girl child, we are working for women, we are working for the disadvantaged population, so that we can bring them in the mainstream. We can provide some livelihood, skill development, nutritional support, so that they come, they learn, they lead, they decide, and they thrive to make a best nation. Thank you very much for providing this opportunity. Thank you.
Thank you, Dr. Rajesh Rana, for that wonderful explanation of the Nikshay Mitra project, and also how each one of us, even sitting here, can be part of that and become a Nikshay Mitra, and also support the Prime Minister's goal of eliminating TB by the year 2025. And thank you for your efforts. I think we need more collaboration with agencies like yours. From TB, going into the next session is the role of community or civil society organizations in complementing the efforts of the national program. We have a speaker, Ms. Elizabeth Michael, who is a trained social scientist and an extensive experience in HIV program for over more than 2 decades. She's currently working as a Director of Operations and Partnerships in IHF India. Previously, she worked at NACO and UNDP as team leader, particularly focusing on mainstreaming and mitigating the impact of HIV through policy change and social protection. During the tenure, she represented India in the ASEAN Summit, Global Commission on HIV and the Law, and other international conferences. She started her career as a counselor at a drop-in center and worked her way up to become the current Director of Operations and Partnerships in IHF India. And she has also worked with many organizations, including University of Manitoba, Canada, and was instrumental in implementing the projects of BMGF and USAID. May I welcome Ms. Elizabeth Michael to talk on the role of civil society organizations in complementing the efforts of the national program.
Good evening, everyone. Thank you so much for this opportunity. And I know the time is running. And like the previous session, intersectionality of many things is there in this presentation, which I had to consider while making this. One is public health lessons learned in India. The second thing is what we are implementing. How do we look at what are my reflections? What are the lessons learned? So one thing which we have understood is that India has the biggest win on polio, and that has achieved only because we have been able to take services to the community. So that is the catch. So how are we in our project taking services to the community and supporting the national efforts? That will be the thrust of my presentation. Can we please move on to the next slide? So our AIDS Healthcare Foundation in India, we are actually the three pillars what we do. We are an HIV organization. We work on prevention, testing, and treatment of HIV and sexually transmitted infections. So first I will talk about access to prevention. Fortunately, unfortunately, when we are talking about this, this public health problem is so much stigmatized, like what we were talking in the previous session as well. A person with HIV, a person who is of a different gender, intersectionality adds to it, stigma adds to it. Every time we talk about prevention, we talk about condoms, it's stigmatized. So government is giving it free, and condom is the most cheapest and the most effective medical device ever founded on earth to prevent sexually transmitted infections, HIV, not only that, even to prevent unwanted pregnancy. But unfortunately, we all, our community is not ready to buy it, not ready to go and take it, not ready to talk about it. We feel so stigmatized talking about condoms. So our greatest challenge was, how do we make sure that we normalize condoms, and what are the strategy? So first thing what we did is that globally, the first online condom store, we introduced that. In the first 69 days, we had 1 million condom requests and 1 million condoms that was shipped. So the best thing is that the identity is not revealed. So you write to us on an email, there's a toll-free number, you say that you need condoms for your personal use, like a Flipkart, like an Amazon cover, without knowing in a brown cover, it reaches you. So you can sit at home, sit at your comfortable space and get condoms. So you don't have, you cross that barrier of stigma of going to some place else and getting and buying condoms. So that is the first thing, and this we instituted in 2017. It's still going on. We have lots of emails that we are not able to kind of even manage. There is a lot of demand of condoms, but unfortunately, I don't think so people can get condoms till today. So we've been also giving it to the government transgender targeted intervention programs, the community-based organization, different other civil society organizations. As AHF, we also instituted the International Condom Day, which is on February 15th, just one day before in Valentine's Day. Globally, in 45 countries, we actually do International Condom Days just to normalize condoms, just for people to touch and feel and understand what we have done. Fashion garments, we have an inflated condom booth, we have many those kind of initiatives where the public could come, touch, feel, understand, normalize condom, understand it's a medical device, it's nothing bad, nobody was going to judge you if you're going to have some condoms. And definitely India is the most populous country in the world, and we know how children are born. So let's accept it, and let's say that even for working on our population, we need to use condoms. Let's normalize condoms and start using it for our medical health benefits. Yes, so this way we've been able to kind of improve access to condoms in multiple forms, through online, through getting it to them, and also through other mechanisms, through all our projects and programs. Can I have the next slide, please? The one before this? Yeah. So next is access to testing. In 2012 onwards, AIDS Healthcare Foundation in India, we are actually going to the community and doing HIV screening. We are so glad that in 2017, National AIDS Control Organization also started the community-based screening, you know, where there will be a van, there will be a set of people, a counselor and a testing person who would actually go to the field, go to the places where there are high-risk population and do testing and then identify people. So in 2017, when the government started even taking services to the community, we thought, okay, now we need to actually move one step forward. If government is taking services, then as a civil society organization, we need to take another step forward. And we sat and thought, what is it that is missing? So what we understood is the time. So sexually active people who are into a profession of doing sex work, they get ready, they come to the street to do sex work only in the late hours, evening hours. And all the services, be it STI clinic, be it the HIV clinic, being the testing or community-based screening, all ends by, let's say, 3, 4 in the day across the country. So we instituted the moonlight, as it's called the moonlight, definitely the moonlight in the night, but there is an abbreviation to it. That's mainstreaming out of network, laymen, IDUs, gays, hijras, and transgender. So when this community actually comes out and solicits and actually does the sex work, we are there with testing, we are there for prevention, and people are identified. We have a moonlight clinic in Delhi where it's open till 10 in the night, from morning 9 to 10 in the night, where that day itself, that person is accompanied to the clinic to initiate on initial investigation, treatment, counseling, and other services. So that makes it different, and that's how we actually try to complement while making more access to testing. Apart from that, we work in 9 states with community-based screening. We work in these states based on timing. Some sites we work in the evening, some sites in the morning, based on the viability of population, and we link them to the government system, making community-based screening much more accessible. So you can see a picture, which is a moonlight van, testing van there, who is doing testing in the night in Delhi. Can I have the next slide? Yeah, so these are some pictures. We're very fortunate enough to have our ex-health minister, Shri J.P. Nadda ji, to visit inside our van when we were doing the moonlight testing. He was very appreciative of our initiative. And these are some pictures where how we do testing. The right one and the below shows how we were doing testing with the metro, when the metro work was happening in Delhi. We did it with the Delhi State AIDS Control Society. Yeah. Yeah, so access to treatment. So how are we contributing to the government here? So government has ART centers, antiretroviral treatment centers in almost all districts. In sub-district level, to a great extent, they have this link ART centers where medicines are dispensed. So what are we doing something different? Definitely, we have 2 clinics like ART center, one-stop shop, where from your baseline surveys to all your medical blood tests have been done with your treatment, everything in Delhi and Mumbai. Delhi clinic is open from morning 9 to 10. I think the only clinic that is the ART clinic that's open from 9 to 10. And the most fortunate thing which we have is that we have a trained psychiatrist as our ART physician too. He doubles up as a trained psychiatrist. Post-COVID, I think the best thing which we have is HIV treatment and providing mental health services free of cost. He even treats mental illness if required with psychiatric drugs, and that has actually made people come back to life, and we have many case studies on that. And I think this is so unique for AHF in Delhi, and we are very proud to have run this clinic for the community. Apart from that, how do we take services to the community? We have something called the satellite clinic. You know, here, these are migrant colonies in Delhi, where if they have to go to a clinic, they lose 1 day wage. Their family is, suffers. So even the family could be affected. So what we do is that as a team, we have registered patients in these colonies. As a team in an ambulance, we go there, we've identified a place. You can see there a picture. So where we actually provide all services from collecting blood samples, doing counseling, giving treatment, and this is happening on a monthly basis, which is a model which we are actually showcasing the government to ensure that people are adherent to treatment. If they have to come, they don't. If you start ART medication, you need to be adherent your lifelong for having a healthy lifestyle. So that's there. In Mumbai, we have a clinic. It's a 30-bedded clinic, and it's especially housing destitute women free of cost who are infected, and they take care of it. So that's something how we make a difference and try to complement. And ensuring access to treatment is much more than the other centers. Yeah, this is my last one, which I would want to say. So we spoke about prevention, testing, and treatment, and this is Girls Act. This is one of my favorite. I would like to recognize SPID, my partner organization, who is actually working on this with us. And this is a very critical one. When we talk about children, when we talk about girl children, we always work in the children with schools, we work with children community, but very, 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 very few people work with children of sex workers, girl children of sex workers who are in the brothels. These girls are just being allowed to grow a little bit to be trafficked into sex work. You know, who works to prevent them, who gives them the reproductive health services. We don't even do that. When we had COVID, we're very glad that we've been able to kind of work with these sex workers. We were talking about social distancing, we're talking about health kit. They didn't even have a sanitary napkin. What health are we talking about? These children, at times, even for sanitary napkin, they have been in a situation where they need to do sex work to get money to buy sanitary napkins. So what is the point? So we are working in communities where we try to prevent children getting trafficked. We try to put them back to school. We make sure that we provide them with sanitary napkins. The next slide. Yeah, so we've been able to do this. Next slide. The moderator is not allowing me to talk.
Just mindful of the time, madam.
Yeah, so we also talk about period poverty, having sanitary napkins. We talk about stigma against periods. We say that it's normal. Girls need not be bullied. They need to be in school. They need to, have every other opportunity like any other children. Because of periods, they cannot be back at sitting at home. So this is an initiative which we do among girls, especially most vulnerable girls, and we're very proud of this program, and we would continue this. Thank you so much.
Oh, a lot of complementing efforts from the AIDS Healthcare Foundation, which are to be, if implemented, to be models for the country, but let's see how things go up. Anyway, thank you so much, Ms. Elizabeth Michael. Next on the phrase, Prince Manvendra Singh Gohil, a Crown Prince of Rajpipla, and from the erstwhile state of princely state of Gujarat, princely state of Rajpipla in Gujarat, and the 39, the direct descendant of a 650-year-old Gohil dynasty. He is a prince, and he is famous as the gay prince of the world. And he is the first member of a royal family to come out openly as a gay to the world. He's the only Indian to be interviewed by Oprah Winfrey 3 times, and has been featured on the show Keeping Up with the Kardashians. He is the chairperson and co-founder of Lakshya Trust, dedicated towards empowerment of LGBTQI communities. He's also brand ambassador of AIDS Healthcare Foundation, and LGBT is developing a dream project, which is like an LGBTQA campus at his royal establishment at Hanumandeshwar for the social and financial empowerment of LGBTQ community. Welcome, Manavji. He's a face to be reckoned with, and thank you so much for your time today here. Please take over.
Hello. Yeah. Very good evening to all of you. With respects to Ammaji for providing this opportunity to us. Do you have my slides with me? Yeah. Today I'll be talking to you about the healthcare access for the trans community. That's the Lakshya Trust, which was founded by me in the year 2000. We have been working for the trans community of course, with the help of the government. We are being supported by the Ministry of Health and Family Welfare, Government of Gujarat, for HIV prevention and awareness about HIV, AIDS awareness amongst the transgender community. And I'm very proud to say that Lakshya started with government grant. We are here today because the government has supported us, has funded us for numerous projects, and they're continuing to fund us for last 23 years. Can I have the next slide, please? Next slide. Yeah. So this is just to give you an information data from NACO, which is National AIDS Control Organization, which gives us an estimate of the transgender population in India, which is estimated at 4.88 lakhs, and out of which there are 70,000 which are estimated living with HIV. Percentage-wise, it's 3.78% of the Hijra trans women who are with HIV prevalence amongst this community. Next slide, please. Yeah, next slide. I would like to talk about this. It was a very historic moment for my organization, Lakshya Trust, when for the first time in the history of India, the Ministry of Social Justice and Empowerment, Government of India, launched something called Garima Grah. Garima Grah is nothing but a transgender shelter home, which was inaugurated by the then minister himself, Mr. Thawarchand Gehlot. And this, the first Garima Grah was started in Lakshya Trust in the city of Vadodara in November 2020. Now, Garima Grah is an initiative by the government where not just food and shelter is provided to the trans community, but also their skills are built, the training happens with the view of providing them employment, with the view of providing them livelihood so that they can live a life of dignity and respect. So again, going back to what the other speakers have said, this is Mr. Modi's initiative, our Prime Minister's initiative, which has brought, changed the lives of so many people, so many trans persons in India, and Garima Grah is one of them. We are housing almost close to 18 to 20 trans persons in our shelter home, and there are so many corporates. The Shell petrol pump has employed them. We have the Bombardier. We have got several other corporate houses which have employed these trans community into their fold. Next slide, please. This was another initiative by the government of Gujarat, again under the Ministry of Social Justice and Empowerment, where the Transgender Welfare Board was formed. And under this Transgender Welfare Board, we've been providing a lot of social entitlements in terms of ration cards, Aadhaar card, voters card, many others. Let me tell you another thing, that India is probably one of the first countries in the world where the trans rights were given. Transgender rights were given. There was a NALSA judgment. Yes, but it's a proud moment for us. I'm actually proud to be an Indian, I would say, that where so many other countries are still fighting for the rights, whereas India got the 2014, the NALSA judgment came up with this, the transgenders were given the rights to as a third gender, rights which were guaranteed to us by the fundamental rights of the Indian Constitution. Whereas I know of cases in America, for example, very recently, Oklahoma state in America is trying to pass a bill where trans persons will not be allowed to go for any kind of sex reassignment surgery till they attain the age of 26. So you can imagine what regressive laws are there in the other countries, whereas India, we are really proud that we have got, our government is trying to see that transgender welfare board is provided and social entitlements can be provided to them so that they could live equally with like other citizens of this country. Next, please. These are some projects which we are working with the Ministry of Social Justice. As I mentioned, we are also running a project by Azim Premji for elderly care project, and some others by Global Fund. Next, please. We have also started, as I mentioned, bank accounts. For example, a lot of trans community want to pay tax. They are earning a livelihood, but they were refused to have bank accounts. And under the Transgender Protection Act, which was passed in 2019, now they can have bank accounts. Now they can have insurance policies. Now they can purchase properties. All that has happened thanks to the government. And also, sex reassignment surgery is free of cost, provided by the government in India to the trans community, which is not there perhaps in a lot of countries in the world. Next, please. As I mentioned, the social entitlements we are trying to provide. There's a transgender card now available. This is another unique feature in India. If any transgender person who identifies as a trans, whether he's a trans woman or trans man or somebody from the Hijra community, you can go to the district magistrate, and we have a special office under the magistrate office where you can apply for a transgender card, and the transgender card entitles you to several rights and benefits which a trans person can enjoy, which has been guaranteed by the Trans Protection Act 2019, which was passed by both houses of the parliament. Next slide, please. This is again some health camps, which amongst the health camps which we have been doing, we have been providing HIV testing, regular medical checkup, STI services, ART referrals and linkages, for hepatitis B and C. We have TB treatment and services also. And of course, we are trying to provide SRS, sexual reassignment surgeries. Next, please. These are some of the community events which we have been hosting. Next, please. These are some events, again, they are trans-specific, and especially providing to the PLHIV. We are also providing nutrition and free treatment. Of course, government is providing free treatment, but we are ensuring that they live a healthy lifestyle, being PLHIV as well. Next, please. This is a very interesting thing which happened. We have a Baba Saheb Ambedkar University, Open University, in Gujarat, in Ahmedabad, and we managed to get in touch with the education ministry, and we are trying to get them educated. They have the right to education, but not many education institutions are giving them education. So we have managed to enroll some of them. I met the education minister. We are trying to include issues of the trans community into the education system, into the curriculum of the universities. And that's also, I think, a very good initiative by the government of Gujarat. Next, please. During COVID period, yes, I must mention this. During COVID period, a lot of help was given to them. Dry ration kits were provided to them. They were provided with blankets. They were provided with nutrition. Lot of, and not just that, the UNDP supported us, and with the help of the National Health Mission, Government of Gujarat, we were able to provide vaccination to a lot of trans community in all four important metropolitan cities of Gujarat. Almost 2,000 vaccinations were provided, because it was very difficult to for the trans to intervene to them and to get them vaccinated. Not many of them, especially from the Hijra Gharanas, they were not willing to get vaccinated, but with the help of the government, we managed to get a lot of them vaccinated during COVID period. Next, please. Yes, you can go on to the next one. this is just some photographs. I guess, next, please. These are the blankets and the provided to the trans community. Next, please. We are proud that the government has felicitated us. The Red Cross Society and the Gujarat State AIDS Control Society has felicitated Lakshya for the best organization working for the trans community. Next, please. We also got a certificate for the COVID-19, working for the COVID-19 pandemic. Next, please. These are some of the advocacy meetings we've been having. We've had advocacy meetings with the political parties as well, where we have our issues with them. Next, please. Oh, okay. So I would just like to conclude by saying that a lot of work has been done for the community. There are a lot of challenges, as we heard the previous speaker, Shivangi, who spoke about some difficulties in the SRS. We need to overcome them, but of course we have to learn from each other's success stories from different countries, and that's why I think we are here for C20. My submission is that trans-inclusive healthcare should be included in the G20 C20 policy paper, and not just here, but this should be also carried forward to the next hosting country. As we know, it's going to be Brazil. So it's a very important part of healthcare, and I firmly believe that trans issues should be also included, as our Prime Minister and as our government has included transgenders. They have given them rights. So now their healthcare is also of utmost importance, and they should be definitely considered in the policy. Thank you so much.
Thank you, Prince Manvendra Singh ji, for sharing that first-hand account of a hard-hit community, the transgenders, as always. This is definitely a story of resilience and the stigma and the challenges associated with the transgender community, especially during health emergencies and, way forward. May I also encourage the audience here to visit in the expo area, the transgender beauty a stall put up by them. They are giving the beauty services there. So tomorrow, while we have the sessions, if you step out into the expo area, please make sure that you visit one of the stalls to encourage them there, in our expo area. Moving on quickly, Ms. Sunanda Nadarajan. Yes, welcome, Ms. Sunanda Nadarajan. Success story of a woman social entrepreneur living with HIV. I don't think I need to go detail much about her. Loretta, I think maybe from the next speaker onwards, could you please take over? Thank you. And Sunanda is founder of Ek Jeevan Hamari Prerna, comes with around 16 years of experience in the field of HIV and disability. She started her social life in 2006 after knowing her HIV status. So she's an openly living HIV positive woman, but also an entrepreneur, a successful one, and also a role model for her community. She met many women like her. When she observes them, she feels that she's so lucky to have maintained a very healthy body and a healthy profile. She continued to work with organizations and excellent in handling any responsibilities assigned to her. She has been a consultant to AHF also. Somewhere she realized that the real motive of life is missing, and then that's what prompted her to found Ek Jeevan Hamari Prerna. Ek Jeevan, one single life itself is a motivation for us. And thank you for being here, and then kindly share with us your experiences.
Thank you. Thank you. First, thanks to Amma and whole team for this opportunity. Before talking about my organization, I want to share the reason to start the organization. In 2006, after 3 years of marriage, I had to abort my child, and my husband left me with my parents and came back to Delhi. After few days, I got a letter saying that I have HIV, so I need divorce. And there is one more sentence added that if you deny to give, I will inform everybody. So I was totally shocked that time. and I have no idea what to do, and I cannot share this to anybody, including my family. Then I went to a hospital and I kind of consult with that doctor. It's a private hospital in Kochi. And she asked me to test again and test that which was positive. Then I asked her what to do now. She told me that you cannot live with your family and husband. So you just go live alone. So I was not much aware about HIV, so I believed that. I just came back to home, and it was very difficult situation to overcome that. And this is the during time World AIDS Day, and there was some information providing in a news channel regarding the testing center in Kochi. I just gone there and consult the another doctor. So he has given the right information to me, and he has also given some organization working for the same field. Then I got the number of Tamil Nadu, one NGO which is working for the women living with HIV. I just called there and asked them that I need one week stay. Then after that I will go somewhere. They asked me to just come. I lied to my parents and left from home. I told them that I am going to husband. I gone to Chennai, which is in Tamil Nadu. And the staff of that organization were very supportive. They always tried to engage me in various activities which they were doing with women. And they asked me to join in that organization. But I feel very bad that time to say someone that I am working in HIV field. So, but I continue there to work, to interact with the women. And then I realized that my issues is nothing. I am so lucky that I am a healthy body. Then I continued there till for 3 years. So after that, I want to move from there to work for children. So I applied everywhere, but I got an opportunity to work for people with differently abled in Delhi only. So they are working for the employment, the people for differently abled for the in employment opportunities. So I was very happy to work there, and also I have involved our women in that employment programs, but it was not that much successful. Then after sometimes I got promotion. I have taken the second in charge for the organization. But the workload is high, and I couldn't get a space for sharing my issues, my personal issues, my feelings. So there it was affecting my health, and I approached AHF and I started medicine from there. After some years, in 2017, I left from there and started the NGO Ek Jeevan Hamari Prerana. Our main aim is to empower women living with HIV and also marginalized women. Right now, there are around 325 women working with me, in which 125 women are living with HIV. I have started with those women living with HIV, and slowly I entered in 3 slum area, where in which one slum there are around 300 women living, and I am providing the work from home facility, which will help to take care of their family, and also can do any work. And today we have the stall here. You can go through that one. And in this livelihood programs, AHF and Impulse have supported a lot for their programs. They have they bought many items from that we made. And this is one of the best, support they have given to us. And my aim is not only to provide the livelihood opportunities to women, but also to develop a team and empower those women to take in charge of this unit and support more women. So we have registered one unit, which the name is Above and Beyond. So that is our main, you can see in our all products, the name. So, and this is my story. And this is one of the conclusion I have to say in everywhere, that all
Hi, can you hear me?
decision makers are here. So I want to say that there are so many programs there are so many support grouping meetings were there. But after this COVID pandemic, so lots of the programs are finished. So we don't have any space to share our feelings, our issues. So we are taking medicine, very strong medicines, and there are so much, we feel that there are so many side effects we are going through. But actually, this is when we are discussing each other, that those will go in different ways. But this is really not good, that whatever information should go the right information.
Okay, cool. Thank you. Thank you,
That's
team.
why we are also using our livelihood unit as a sharing space for the women living with HIV. Thank you. Thank you for listening.
What an inspiring story. From what would have been a very dreadful experience to creating positive impact on other people's lives who are living with HIV. If one person can do this, there are so many. We are a country with 2.4 million people living with HIV, and 50% of them are supposed to be women, you know. And Sunanda is a role model for sure. Sunanda's Ek Jeevan Hamari Prerna is a model NGO which reflects that, you know, with her own empowerment, she wants to make empowerment. She wants to transfer that empowerment to the rest of the community members also. They have a stall here. May I encourage all of you to go there tomorrow or by tonight, whenever you get the time, and encourage them. You know, they have some little products that they make through these communities. And, you know, they're here for showcasing it. We, as an HF and Impulse, found that the tag that she has put for her products, above and beyond, it should actually be sufficed by all challenges, you know, above and beyond all challenges that she faced. She's still a successful entrepreneur today. May I request a round of applause for Sunanda Nadarajan again. Thank you, Sunanda, for sharing your wonderful story here. Loretta, my co-chair, Deputy Global Chief of Advocacy Policy, joining us from UK. May you please take over and you know, do the advice for the next speakers. Thank you.
Thank you, everyone. But first of all, my apology. I think my earlier message about like testing, it seems that the audience listened to that. If that is the case, my apology, because we were trying to test my audio. So welcome to part 2 of Lessons from India, Public Health Adaptation and Reflections. And this event is brought to you by AIDS Healthcare Foundation, AHF, and India Cares. Well, today is World Health Day, which marks the 75th anniversary of the establishment of World Health Organization. The global health situations and landscape have changed so much since then. And especially in the last 3 years, the world has lost 6.9 million precious lives during COVID-19 pandemic. While we mourn the many lost lives, the world is on the path to reset itself. The SARS-CoV-2 virus has thrown our world upside down, and we see inequality in accessing to healthcare. We see greediness of pharmaceuticals in making huge profits due to patent rights. We see wealthy countries hoarding excessive vaccines that their nations even could not absorb the volumes and had to throw away the expired vaccines. But hearing a lot of the stories that we have just heard today, and when we look deeper into each country, deep down in every state, in every county, and also every provinces, we have strong civil societies and community groups who work so hard to keep the community together, to keep the community alive, and to keep voicing their concerns and make themselves louder. And in this regard, I'm very honored to have the opportunity to introduce our next speaker, Mr. Biasmaya Kumar Ralu. Bisyama is an LGBTQA+ activist working in the field of HIV/AIDS since more than 7 years ago. He has proven his leadership during the advocacy effort in the repeal of IPC 377 in India. He is the recipient of the top global diversity and inclusion leaders in 2018. He is a trained computer science engineer and multimedia designer. And currently he's working with AIDS Healthcare Foundation India and leads the Impulse India. It is a city-based LGBTQA+ chapters in Delhi and also in Mumbai. He spearheaded the Young Leadership Program. This is very important. We need to include our young people. He spearheaded the Young Leadership Program for creating a cadre of young leaders from among the community. He is also instrumental in facilitating events with a purpose to reach the unreached MTH community and thereby improving access to healthcare services, particularly HIV and also mental health. The floor is yours, Bisyama.
Yeah, thank you, Loretta. Thank you so much. My humble pranams in the lotus feet of Amma. And good evening to all the esteemed guests present here today and my co-panel members. Good evening, everyone. So today, I will be talking about how Impulse can contribute in way forward to achieve the first 95. So I'm not sure how many people are familiar with the word, what is 95? You must be surprised. So we can go through that first. Then I can explain how as Impulse, a group of volunteers from the LGBTQ community, especially from the gay community, the gay men, you can see a stall also there. There are a lot of vibrant colors. So how we can help in achieving the first 95? Can we please go to the next slide? So it's called 95, 95, 95. So the very first 95 is there is an estimated number of people living with HIV in India. So the first 95 is out of those estimated number, 95% people should know their HIV status. Then the next 95 is out of those 95 people, 95% people, 95% people should be linked to care on ART, antiretroviral therapy. And from those 95% of people, another 95% of people should be the viral load, we call it VL, viral load should be suppressed so that they cannot transmit the virus to other person. So that is called 95, 95, 95. The very first 95 is prevention, wherein the other two 95s are care and support. So the very first 95, we are talking how we can know the status. So this is some estimation, all you can see on the screen. There is an estimation of 2.4 million, like our chair mentioned in the previous, session, when the previous speakers spoke about it. So there are estimation of 2.4 million people who are living with HIV, out of which 77% people know that, they are HIV positive, which is 18,57,000 to it, almost 1.85 million. Which is overall 65%. And out of those 85% who are on treatment, who has suppressed their viral load, which is overall 55% of the 2.45 million people. But wherein the global data says total 85% people who are living with HIV know about this status, out of which 75% people know that they are on the treatment. And from those 75 people, 75% is people, 68% is people know, their viral load has been suppressed.
So now we have to achieve the 95. We have a goal to achieve it. So how we can achieve it with the help of Impulse. So the next slide is it's a very particular slide for a specific community, which we call it MSM community, men having sex with men. So, or we can say the gay community. So this is the estimation that we have as per the government data, National AIDS Control Organization. There is an estimation of 3.57 lakh people who are from the gay MSM community who are living with HIV. So the prevalence rate is 3.26%. That means it's like in every 10,000 people, 10,000 MSM gay men, there is 326 people who are tested as positive. So that is known as seropositivity. So how we can bridge the gap? So how we can identify the hidden population? To have that, to find those population, we have two approaches through Impulse. So Impulse is a global organization, global group, I would say, and affiliation of AIDS Healthcare Foundation, and which is for the gay man, run by the gay man, so that we call it for the community, by the community. So in India, we call it LGBTQ community because we want to be as inclusive as we can. Here we have, next slide, please. Yeah, so the very first approach is having event with purposes, testing on site. So under Impulse, we do organize community-based events. When we call it events, it could be anything. For example, there is one event happening Palika Park in Connaught Place. There is an open event, we had it. We invited the community members. We had sessions on condoms. We had sessions on on safe sex practices, on mental health, how people can cope up when they know about the status. And also some fun activities you all can see, some Garba dance and some theme-based activities we do organize. That actually attracts the community members. They do come to attend the event. At that very moment, we place a free HIV testing booth with the support from AHF. So people can come, they can have their gala time. At the same time, they can know the status. These are the population who are do not go to the government setup to get themselves tested or not aware of other facilities. So this is one setup under Impulse we are trying to do to find the hidden population and to help the government in achieving the first 95. The second approach that we have, it's like assisted self-screening assessment program, ASAP. Whenever there is something emergency, we call it please do it ASAP, right? So now we have an abbreviation for that, assisted self-screening assessment program. Here, what happens, an Impulse buddy is there, we call them Impulse buddy. So if you need yourself to get tested for HIV and you're not comfortable coming to a setup, a government setup or a private setup or a clinic, so you can get yourself tested at your preferred location. All you need to do is fill an online form, and then we will do the risk analysis, and then a volunteer will come to your doorstep with a test kit who will assist you in getting the test done. That's very much confidential. The report stays with the counselor, and if that person tested as positive, then immediately we link them with care. So right now we are running this program in New Delhi and Mumbai as a pilot. And I'm really thankful to Dr. Sam. This is his brainchild, but giving the opportunity to Impulse to run this program. This model has been really successful in both the cities. The prevention rate we have got in the terms of HIV and syphilis. In this test, we do provide both the testing of HIV and syphilis is a rapid testing. So the prevention rate is really high. So we can see there is a small video. It's a quick 30-second video. We can see that, so you can get the idea how exactly it works. Can you please play the video? Oh, it's not working. Yeah, it's on that. Audio. think there is some technical issue. The audio portion is not there. But yeah, so like this is like you all can read over what it like mentioned, fill up an easy form. We will call a given number to confirm your appointment. Our in-person body will come to you at your preferred location. They will assist you for your self-testing. Make it easy. So like you don't have to go like take a leave and go somewhere, or like when like you may like think like why I will go, but this is like an easy option that we are implementing in Delhi and Mumbai. So yeah, this is how we are trying to reach our first 95 and complementing government's work, National AIDS Control Organization, as well as like DSACs and MDSACs work, so that we can achieve our first 95 on these targeted communities. Thank you so much.
Thank you very much, Ms. Yama, for this very creative, actually, approach in really getting more of the community members, particularly gay men, to have access to HIV testing. So kudos to everyone in Impulse for the great and innovative work there. Now, I would really like to invite our very important final speaker, who is actually joining us from Brazil. And I'm much honored to introduce Ms. Alexandra Nelo. And Alexandra is a feminist, a journalist, specialized in communication and health, and with a graduate degree in diplomacy and trade affairs. She is the co-founder and general coordinator of Gestos, HIV and AIDS Communications and Gender, an NGO created in 1993 in Recife in Brazil, which acts at local and international levels. In 2012, she was nominated to the high-level task force of ICPD and followed all post-2015 negotiations. Her advocacy resulted in the inclusion of people living with HIV in the text of the 2030 Agenda Resolution. In Brazil, she led a campaign for financial transaction taxes and is the co-facilitator of the Civil Society Working Group for 2030 Agenda, a national network with over 60 members. She represented the Latin America and Caribbean regions in the UNA's Program Coordinating Board during 2 terms and was the keynote speaker for many high-level meetings at the UN, as well as International AIDS Conference in Durban in 2016. In 2018, she received the Monique Rudigi Award for her work on LGBTI rights, and in 2019, she was awarded by the Regional Labor Court of the 6th Region in Brazil as a human rights defender. Currently, she is the operative partner for the Women's Major Group at the UN. Gestos is a member of the C20 Troika, being responsible for taking our C20 torch from India to Brazil in 2024. So let's all welcome Alexandra. It's quite early in the morning in Brazil. Bom dia. And Alexandra, over to you.
Thank you very much, Loretta. Namaste to all of you. Greetings to distinguished and honorable panelists, and congratulations to the Working Group on Health, which organized this very, very important event. As Loretta mentioned, my organization was created 30 years ago to respond to the HIV crisis, and our main area of work is health. So this conversation really today speaks directly to my heart. So it is an honor to close this session moderated by AHF, a long-time partner we have in this fight against AIDS, and it's an honor to be here representing our Troika, and also to trying to speak about some lessons learned and that we plan to take to Brazil, definitely. I think this is a timely moment also to focus on finishing the work we have ahead. We still have a few months ahead to continue working, but also it is important to start planning ahead for the work we need to develop in Brazil. So I'm very happy to be here with you all. In general, I believe we have this responsibility of taking a strong message to G20 in Brazil, as we are doing here in India, reminding them about the commitments they signed for guaranteeing the SDG 3 of well-being, to guarantee the right to health, and also to guarantee the universal access to health within peaceful and more just societies, as we all discussed it here this morning, this evening, actually, for you. It must be done in a context where people are free from stigma, free from discrimination, and free from inequalities. So I think the first lesson and thing that we'll take forward for Brazil is definitely we will take this integrated intersectional health approach. I think it's happening here in India in a very comprehensive way. And we also understand that health is a human right, and its full concept as recognized by the WHO. And it was excellent that Loretta reminded us that today is the World Health Day. But the concept that we have been using for all these years at WHO, it is that health is much broader than the absence of disease. We need to push on that. And of course, as we all discussed it today, we saw examples, we saw the work that has been done in so many areas. Of course, the right to health also includes issues around access to reproductive health and rights, mental health services, the implementation of the TRIPS agreement. It requires intersectional approach that leaves no one behind, including women and girls, youth, children, LGBTI people, people with disability, people living with AIDS, indigenous people, migrants, Black people. We need to talk about everyone and always remind our governments that we are all equals as human beings, and we all have the same rights. The second point is that at this moment, we need to recognize that the world is really trapped by so many crises. We know that. But also, we know that it is also plenty of solutions. We have been talking about solutions in the past months. And as in India, we will continue focus on these solutions, planning for the short, medium, and long-term approaches. I think someone said today that we need to go beyond the crisis intervention mode. I absolutely agree with that. We need also to understand that going beyond this crisis intervention modes includes to dedicate time to address the current crisis. And for me, I think it is important to hear from you here today that we need urgent responses, particularly for addressing the food insecurity, the increase of poverty, the gender-based violence, which is epidemic recognized by WHO, to guarantee access to clean water and sanitation and education, and particularly education and health. I would say that the 6 main areas I just mentioned are absolutely essential to guarantee the right to health for humanity. Also, in order to implement this holistic approach, we need to consider that we need to address the social and the economic determinants of health. I heard that many, many times during our session today, and I'd like to add that in my region, Latin America, these combined crises are worsened by the growth of religious fundamentalism in our regions. Therefore, it leads us to my third point, which is in Brazil, no doubt, our plan following India's and other countries that worked with C20 steps. We will need to take the public approach to health as central to our work. We have heard that besides creating the health problems, some sectors are not contributing enough to finance our right to health. And we need to make sure that our rights to health will fit in our budget, in our public budgets. And it's very concerning that although they are not even financing the right to health, they are creating more problems sometimes to health. There are some very complicated industries that are still receiving support from many, many governments. Let's say industry of food, processed foods, tobacco, and many others. The list is quite long, but it is concerning to see that their influence still continue to grow within the multilateral bodies. And I think this is a particular area you should also focus our attention within the G20 work for Brazil. So, and craft some very key messages showing that we are aware about what is going on. I think this panel was very informative to highlight something that it's very keen to my heart, which is that our history of AIDS fighting this drug monopoly has been repeated with the COVID crisis. So we have seen countries from the global north just prioritizing intellectual property rights and profits over the lives of our countries in the south. And this is so unjust. We need to continue to talk about that. So in Brazil, definitely our commitment is to continue pushing to remind the G20 leaders that it is time to change this private first approach. We will continue to push our governments to take back this drive seat of sustainable development, because this is the only way we can move forward. And with all that in mind, I can say that it's possible to foresee two kinds of blocks of work. The first block of work is related to organize our recommendations around addressing systemic barriers and moving forwards with the integrated rights approach, abandoning siloed approach to health and emphasizing system-wide policy coherence at all levels, especially for linking health with social, economic, and environmental sectors in our areas, ensuring accountability around all commitments made for guaranteeing health to everyone. And the second area, I think it's calling, and I think this also, it was another area well covered by this session today. It's calling for the proper recognition of the community-led responses for health, including with examples from our leadership in responding to AIDS and COVID-19, as well also for achieving the SDGs as a whole. And for that, of course, we need to remind them that they need to protect the people. They need to protect the human rights defenders. They need to protect our civil society, civic space. And it is definitely time to recognize the contributions and recommendations made by our communities at the international, national, and local levels. And it's time for them and for the international cooperation included support our tireless work of monitoring, implementing policies, and trying to have more rights-based budgets decisions in order to guarantee that no one will be left behind. I think that in general, in a nutshell, as first thoughts, these are the key points I'd like to put forward here. But of course, we have months ahead of working together to conclude our work in India. But I can assure you that I am absolutely aware of our responsibility of making sure we will have a C20 in Brazil that will provide the necessary continuity to the push and recommendations we have put forward so far. And for sure, you can count on us to develop a C20 Brazilian platform in collaboration with all of you and in the most inclusive possible manner. So I'd like to thank you very much for having me here and to giving me this opportunity to start sharing with you some ideas ahead while continue super committed to continue developing this work with you all here until we conclude our tasks with the C20 Summit. To finalize, I just would like to remind you that in September, there will be the second high-level meeting on universal health coverage at the UN. And I think it's absolutely important for us to see how to bring and to create bridges between the recommendations we are bringing here for the C20 and the language you'd like to see approved in the next high-level meeting on universal health coverage at the UN. So it is an honor. Again, please count on me. Namaste. And we will stay and continue together. And I wish you a lot of love and peace for the work ahead. Many thanks.
Wow, what a wonderful speech, Alexandra, and obrigada. And your points are really like music to my ears, particularly the advocacy on inclusion of everyone, to make sure that everyone have access to healthcare. And this is a fantastic, great reminder to us all. And also the way that you help us to connect all the dots and all the upcoming events outside of this meeting room, outside of this Zoom windows are also like so important for all of us in here, because I believe that all of us who's joining us online or in person in India will definitely, you know, have a role to play in here to really encourage people to improve the access to health and also healthcare. Thank you very much. Now, I understand that we might have a very tight time in here. So I would like to ask Dr. Sam, since I cannot see the audience from the floor, would you like to open the floor a bit to for any Q&A?
Yeah, I think if there are any pressing, yes, I think there are some hands up. Yeah, maybe we should help you with the mic. Can you just pass it? Do we have other mic?
Good evening, everyone. Thank you so much for giving us a glimpse of all the amazing work that you have been doing in your respective organizations. I'm Runjun, and I am from Medicine Sans Frontiers. I work as a policy advocacy officer based in New Delhi. My first question is, since it's good to know about the work at Impulse, and also since AHF is here, one question that particularly bothers me right now is that we have a facility of advanced HIV in Patna in Bihar, where we see a lot of population coming with very severe opportunistic infection. And while we are trying to, do our best to address those, we also see a lot of stigma-related issues and mostly in public sector hospitals, where while we are looking forward to the 95 goal, without looking into the aspect of stigma and discrimination, as well as looking into the OIs that is still killing primarily the PLHIV population, and mortality is very high. And the fact that we do not have services required for all those OIs, how do we really, go forward to attaining that beautiful goal of 95? And you, in your respective organizations, are you looking into it to somehow contribute, or to somehow advocate, so that we as a country have the advanced HIV package that is put forward by WHO in our national program? So that's one for HIV. In terms of TB, yeah, it's good to have that goal of eliminating TB by 2025. But looking at all the issues of how pediatric TB is highly neglected. WHO's 2021 data says that 60% of pediatric TB population goes without, 96% goes without any kind of testing or diagnostics, and never been put on treatment. So pediatric TB is still a huge issue, and I think it would be good to somehow look into what all we need to do in terms of addressing the diagnostics and then the treatment part of TB among pediatric population. So yeah.
Bisma, you want to take the first question?
Yeah. So I'll speak on behalf of Impulse, and I would like to request if you or Elizabeth can speak on behalf of AHF. So answering to you, thank you for your question, for bringing up addressing other cities. However, we have certain restrictions as Impulse, we have operational in New Delhi and Mumbai as of now. So it is a very city specific, I would say rather a volunteer group, and identifying volunteer in other cities also a task. When I say that, you're talking about stigma. So to remove that stigma only, we introduced the ASAP project so that, people won't feel stigmatized to go to a center, a facility center to get themselves tested, because going there and getting tested itself is a stigma. We know that, right? People do not want to go to in a clinic and say that, we want to get tested. No, it's not that common. So that is one thing we, as a pilot project, we introduced last year in Delhi and Mumbai, so that, at least we can cover these cities. And maybe with the learnings, we can recommend these things to other cities, if not with Impulse, maybe other CBOs, government entities, SACs, and probably NACO, maybe we can request. So that is one thing we are trying for our end to complement the first 95. But yeah, talking about the other states and cities, I would like to request if Dr. Sam can take that question up.
Hello. Yeah, also to answer your question on the increasing number of OIs, opportunistic infections that you are seeing, and especially in a state like Bihar, when we stepped in with our testing program in Bihar, we were quite expecting that, there'll be a lot of cases, and that was proven to be very true. The positive prevalence in Bihar happens to be more than 2.5%. And we are just one NGO in some few sites. And there is I think there is a problem there. And then why OIs? Primarily because they are late presenters, and there is advanced HIV in most of them. Their CD4s are coming down, and that, of course, leads to OI, right? So, if I want to twin it now both together, the effort of ASAP project, for example, initiating the testing, self-testing, not really self-testing, but assisted self-screening through an Impulse buddy, through for example, a person from the gay community as a peer tester, and we call it as Impulse buddy. It might be one of the solutions towards reaching and unearthing this hidden HIV positivity among the, especially the sexual minority population. That could be one of the steps. We can talk about this, but I'm so glad that you brought up this point, because I know MSF is trying to do a lot in this space, and then, thanks for your presence here. But I want your second question to be addressed by Dr. Rajesh Rana, if you may. Okay, so Dr. Rana says he's not the appropriate person, but you still want to. Okay, so he feels that the CTD is the best person, but of course, echoing with MSF, AHF definitely is a advocacy organization, and we definitely follow your access advocacy campaigns, especially for the pediatric, diagnostics as well as treatment. And then we stand by you because you are the global leader for TB advocacy in many counts. I mean, not in all counts, but in many counts. And I'm happy that, MSF is represented here. But to take your question directly, I think, Dr. Rana advises that it should be addressed by somebody else here. But I think, it's time. Loretta, I think I'm not seeing any other hands up as of now. Since there is paucity of time, would you like to add something else here?
No, I think, are you all having dinner after this?
Not yet.
So I think maybe, let's make ourselves like lovely and amazing, maybe I can just do a very quick wrap up, and then people can enjoy dinner, the welcoming dinner, if I'm correct, tonight, and also enjoy the festive celebrations there. So I just want to say thank you to all our amazing and also inspiring panelists. Our first speaker, Deepak, he highlighted the importance of country leadership. He cited India as a shining example as a world leader. Together with South Africa, made a proposal to the World Trade Organization on waiving patent rights in the duration of a pandemic to accelerate access to technology to produce medicines and vaccines. Rajesh, thank you. You reminded us it is crucial to increase nutritional support, counseling to TB patients in order to help them to stay on treatment. And let us remember this number. In 2021, TB claimed 1.6 million lives, and more than 10 million people acquired TB. There's a lot that we can do, and we should do it now, and we should do better. Elizabeth, she shared the experience in HIV prevention and testing in India, but the most important thing is we need to start where the client is. The Moonlight program is a star. So I think if we don't see Elizabeth during the day, you will see her under the moonlight, because she's reaching out to the communities deep in the hard to reach areas together with our volunteers and other staff members and also NGO partners. Now, Prince Manvendra, my friend, you beautifully shared yours and also your organization's amazing community-based services to the LGBTQ community. I am literally speechless about the advocacy of bank service for transgender women and men. So bravo to you, Prince Manvendra, and to your team. Great work. Sunanda, your personal journey living with HIV humbled me and everyone in the room and also online watching live on YouTube, and how powerful and empowering it is for us all to learn from you. Let us all to support you and also many other women living with HIV and to create a supportive and stigma-free environment. Ms. Maya, thank you for shining the light of community involvement, and community members have a role in improving access to health services. And good luck to the great work done by Impulse. I know that Impulse has been really growing globally, and your experiences will definitely help other chapters of Impulse around the world to grow and thrive. Alexandra, she reiterated the G20 leaders must defend universal access to health. This is great advocacy, and we need to push for a broader definition of public health, which is not simply of absence of disease. We need to include everyone, including all subpopulations in here. And we need to all support what Alexandra have advocated in here is we need urgent response to food security, access to clean water, education, health, and make sure that rights to health is sufficiently financed by the in the national budget. Now, thank you all for joining our curtain raising event. Namaste. As part of the Civil Society Voices, AHF has been engaging in the C20 process in the past many years. An event like this is crucial to bring the issues concerned the civil societies most all the way up to the higher political platforms, such as this one, and also the upcoming C20 Summit and the G20 Summit in India, and then moving forward to Brazil. So let's make use of this C20 and this G20 process wisely and creatively. And at the end of the day, G20 is not G20 without the support of its people. So let's use this opportunity to advocate for health equity. Good evening, good night to you all, and also those who join us from around the world. Good morning and also good afternoon. This is a fantastic event, and we wish the remaining part of the International Holistic Health Summit great success. Thank you very much. Namaste.
Just in conclusion, AHF, as AIDS Healthcare Foundation, we look forward to engaging with our Brazilian colleagues under the leadership of Alessandra Nilo. She's part of the Troika. She's definitely going to bear the flag for the next year. Alessandra, we're so happy that you are with us today. And you're going to be back with us, after Nagpur. We enjoyed together. We worked together. We saw the tiger together, by the way. And we will see the Jaipur. We will meet in Jaipur and also work towards, bringing our voices, the civil society voices in the C20 in the coming years, and to continue building upon the contribution of all prior to the, next summit. So thank you once again. Thank you for all your patient hearing and patient listening. This has been a wonderful day for us. Thank you so much. Thank you for your patient listening. Thank you, my panelists here. One word of thank you from for all the panelists here. Thank you very much. Thank you, Alexandra. Thank you, Loretta.
Thank you, Dr. Sam Prasad and the panel speakers for reflecting on and sharing their perspectives. With that, we conclude the curtain raising panel discussion events. We will now begin tonight's cultural events program. I'd like to invite Dr. Sam to introduce